Start off a little bit about myself. I'm basically going to talk a bit about upper limb surgery and upper limb conditions, okay? And I'm actually recording this, so we'll see how we go. Sometimes they don't work out, but if we can get up on the YouTube channel, we'll put it up there and you can watch it back later if you've got nothing else better to do. Go back a bit. So a little bit about myself. I'm Adelaide born. I actually trained here at the University of Adelaide and completed my medical school. Always liked orthopaedics right from the start and decided to basically head down that path. In trying to get onto orthopaedics, I headed over to the UK, and that's where I met my wife. Came back to train over here in Australia, finished my training. Went back to work in the UK for 5 years and thought I'd get some more experience over there. Turned out that I hadn't had enough years of orthopaedics under my belt because I got through quite quickly. So I did a senior registrar job at Queen Elizabeth Hospital for a year, which was a fantastic job, I loved it. And having worked in the UK and gone and done visitations over in different areas, including Italy, where I learnt a lot of my arthroscopic surgery, decided to come back to the UK, back to Australia, where I've been working for the last 15 years. I'm now head of the upper limb service at the Queen Elizabeth. I've taken a clinical academic role at the university and teach the fourth year medical students and lead clinician in the MSK. And so really also director of training at the Queen Elizabeth. So I've got a fair few things under my belt, but I really enjoy the teaching and education part of it, so hopefully enjoy the night. So as part of that, actually, I was just saying before, during the COVID lockdown, I set up my little podcast series, which a few of you have actually listened to already. It's a bit of a, as I say, it's a bit of a laugh to do it. Actually, I felt like these events are more about trying to get a feel of what actually really happens in real life, as opposed to someone giving a lecture or reading a textbook. So real life events, and the medical students don't really get that with the COVID because it's sort of been and in fact all of us have been a little bit sort of socially distanced. So I thought if I set up a pragmatic approach to people and interview medical specialists in different areas of medicine, it might give a feel of what it's like being around the hospital when you used to sit around the tea room and having a chit chat. So Glenelg Orthopaedics, I'm based in Glenelg, so we've got our area down there. But luckily, I've been joined by Charlotte Nash or her team from Full Circle Hand Therapy, and if we click on that, that's the team there. And the advantage of having a hand therapist in the rooms is that we've actually got the ability to, for the post-operative care, actually give both hand therapy, but also make up splints, and also treat those patients that don't need surgery. A lot of the patients in the upper limb don't need to go straight off for surgery, and a lot of it's just rehab, including particularly the tennis and golfers' elbows. One of the extra advantage for me is, as a sole practitioner, is occasionally I'll get a phone call from a GP saying, look, I've got a fractured wrist, I can't put a plaster on, can you see him urgently and get the plaster and do the need for? And I might be caught in theatre, and I can actually organise for Charlotte's team to put on a thermoplastic splint, which is more comfortable for them in the first place, and is easier for pressure care, and they can put that on and I can catch up with them later on. So there are certainly some advantages of having an upper limb service in my rooms. And I really appreciate that. If we do move back to the thing, hopefully, no, that'll play up. Go back to the first slide. What I've also incorporated recently in my practice is the use of an ultrasound machine too. And that's just in the last few months I've decided that these now portable machines, which have really come down in price and actually a lot more advantageous, can be used hooked up to an iPad and give patient feedback to the patient in the post-operative recovery or even in pre-operative assessment. So if we look at this is an ultrasound of a finger. There are the tendon moving above, so metacarpal phalangeal joint and the flexor tendons. Or you can actually go to the shoulder, and that's just done on the iPad. We can show that to you later. So hopefully. There's the shoulder, and you'll see the bicipital groove appear just there in this area, just in that area there, with the biceps tendon in it and the deltoid over the top. Moving back, also, my whole idea is to try and provide a quality care service, and that's why I've also produced a lot of information online. I enjoy the podcasts. I've also got a little booklet for you, which I've included in there, so you can read a bit about it. So if you have a bit of time in the car and you want to listen to a podcast on different areas, that's all available there for you. And that's the podcast. So when I approach the shoulders is always a good topic to talk about. Everyone loves the shoulders. They go, how do you assess it? And really, I use the same technique I teach the fourth year medical students, I teach my registrars come up with their exams, is to really make things simple and straightforward. It's not that hard. Okay, I like to use the rule of threes when I assess someone. Okay, so when I go to assess someone, I'm looking at, basically when we take an assessment, we take a history, we do an examination, we do investigations. Okay, the history is being the assessment of, sorry. Okay, the history is how we make our diagnosis. Examination is how we confirm our diagnosis, and investigations help us stage the condition to determine treatment options and determine prognosis. If we look at that, we go use the rule of threes. Now, the rule of threes is an English technique. I don't know if any of you learnt it in English. I didn't actually. In fact, my daughter, when she was asking me to mark an essay for year 12, I looked at it and she said the rule of threes, and I thought that's exactly the same technique I've used all my life. Okay, dividing things up into simple methods. When we go to assess things, we need to remember everything. We need to know things in full detail. So if we go to here, when we go and assess a patient, we can either try and learn a surgical sieve, you know, the vitamin D, vascular, inflammatory, traumatic, autoimmune, metabolic. It doesn't actually help us. When we go to assess a shoulder, we want to know how we actually see the patient. We might see them electively, or we might see them as a traumatic presentation, i.e. in a clinic or in an emergency. Or it might be a mixed picture. It might be someone with a dislocation which goes on to recurrent instability. So the rule of threes helps us a lot. When we go to assess them, we do the history, we do examination, we do investigations. We investigate them. We might just start off with the x-rays, ultrasounds, and then go to more specialists like an MRI scans. And when we go to treat them, we might give it time, try simple injections and physiotherapy, and then surgery. Now, I like to think of the rule of threes, but of course everything occurs in a Gaussian distribution. So we've got a distribution like a binomial curve. 3 is the most common number. We've got 2s, 3s, and 4s as the most common scenario. So that's how I tend to think about it. Okay. So when we go to shoulder conditions, people can get caught up about, well, what can go on in the shoulder? What's actually occurring? Well, really, it comes down fairly simple. We've got our traumatic presentations or our elective presentations. Okay? Someone falls off a push bike and they had a trauma. What could be injured? Well, they could have a fracture, a dislocation. They could present occasionally with infection, or they may have torn a tendon. Okay? It's not that hard. I say to the medical students, what could be fractured? They all think, and I say, well, keeping the answer simple, a bone. A bone can be fractured, right? And how many bones make up the shoulder? Well, lo and behold, there's 3. You've got a clavicle, proximal humerus, and the scapula with a glenoid attached. I said, what can be dislocated? They go, oh. I said, a joint. Okay? How many joints make up the shoulder? Sternoclavicular, AC joint, glenohumeral joint. What can be infected? Either the bones or the joints, or the soft tissue around it. And the tendons tears that occur, rotator cuff tears. Okay? So, electively, it comes down to people go, oh, there's elective presentation. This person's got chronic pain. We can't work out what's going on. You go, well, it's not that hard. You got the most common things that occur, the rotator cuff spectrum. Okay? Now, how many muscles make up the rotator cuff? Well, there's 4. You know that rule of threes, but 2s, 3s, and 4s. You've got your supraspinatus, infraspinatus, subscap, and teres minor. But teres minor, nothing ever happens to teres minor. He's that guy that comes to the party, doesn't get involved. He sits in the corner, goes home. You don't even know him. You know, so that's teres minor. Nothing ever happens to him. So you can get tears, but it's not really that bad. Usually, you think of any rotator cuff tears, the teres minor is always preserved. Okay, it's pretty rare. So you've got a rotator cuff, and of course, the rotator cuff spectrum involves bursitis or tendinopathy. It's really just the age that makes up the difference. It's really the same. You get rotator cuff tears, and within rotator cuff tears, you get some instability associated with it, which leads to secondary arthritis. Now, the other things that occur in the shoulder could be primary arthritis. You get primary arthritis, which goes along with secondary arthritis. And as part of that, I say to the medical students, how many types of arthritis are there? And they try and think about it, and I say, well, there's 3 really. You've got primary, secondary, inflammatory, or the rheumatoid type conditions. And the rheumatoid have about 40 different types of arthritis, but that's a specialist area. If we go down to the other conditions that occur, where you get the frozen shoulder, of which there's, I usually think of it as 4 stages, but really there's 3 stages. Again, the number 3 appearing again. And then we've got referred pain from the neck. So when you refer the patient to see me with a really difficult diagnosis, I've got 4 diagnoses to make. I've got my referred pain from the neck, I've got rotator cuff, I've got arthritis, frozen shoulder, and I could have some instability, but those people say it feels like my shoulder's popping out of joint. Okay? The old label tears, the old, the pain, it's not getting better. This is for the physios. They would have been taught, oh, the pain doesn't get better, it hasn't got better with all the treatment. It must be a slap tear, but the slap tears are really going out of favour. Okay, the old idea of the slap tear causes chronic pain. Yes, the label, where the biceps attached to the superior labrum and it can tear away from the glenoid, can cause pain, perhaps if they're throwing things and they feel something going. But really, it's not that common. Okay, most slap tears are actually degenerate in nature and probably incidental in finding. And we found that in the past where we used to repair them, it didn't make a difference to them. And a lot of guys have gone away from trying to repair labral tears, and for that reason, is doing a biceps tenodesis or biceps tenotomy in that scenario. So the old biceps problem and labral tear is probably not as big an issue as these other four main diagnoses. Now, I know that the physios and everyone will be focusing on the different muscle groups that could possibly be involved, but really, as a surgeon point of view, it probably doesn't make that much difference. And really, the treatment, I know you could just try and isolate the individual muscles and try and individually train those for prehab and also post-op. But that's really your specialty, and that's why I leave it to you. So when the patient says, oh, the physio wants to know for sure what muscle exercise I want you to do, I go, look, I'm happy if it's working for them. And if it's not, well, we need to look at a different pathway. But there's not always one particular answer. I know you may find that something works better in your hands than another physio finds in that hand. But usually I try to think of the shoulder conditions as purely that group of conditions. Really, that's all there is. So when we go to assess a patient, I wrote down what are the important things that I take into account. And these are really them. Okay, so see if we go again. So the age of the patient. Okay, if they're older, they're going to be an arthritic patient versus a younger person. So a frozen shoulder. So the classic one is I get an 80-year-old being sent along with possibly frozen shoulder. And I go, well, 80, they've had a few issues. It's more likely to be an arthritic shoulder. Okay, younger person, more likely to be frozen if it's a stiff shoulder or maybe some instability issues. Obviously, the past history is important. If they've had numerous recurrent instabilities and had surgery, you've got to be worried about arthritis. Side of pain, the classic is the pain that's felt in the neck. Well, I just all may do that. So the pain that's felt up here in the supraspinalis fossa and down the middle scapula, that's classic for neck. And I think it's known as cloud signs, but cervical causation. Shoulder, lateral impingement and rotator cuff problems are felt here, usually. Okay, anterior glenohumeral joint, so for frozen shoulders or stiff arthritic shoulders anteriorly, neck here and posteriorly. So nothing always obeys all the rules, but we go for. But it's all. They generally tend to be the common things that occur commonly, and most things tend to favour these main rules. Motion. Now that's where it's going to be going. I'm going to call up Aidan now. Aidan's going to be my model for the day. Aidan's kindly come along to be involved. Thank you, Aidan. So when I go to examine Aidan, right, the first thing I'll do, I generally routinely check the neck out. So you can check your chin on your chest for me, chin up the ceiling, lateral motion, ear on one shoulder, then the other shoulder, and then chin on one shoulder and then the other, and then chin on this shoulder and then the other shoulder. And if you're stiff in any of those positions or it's causing pain, it makes me think neck. It's pretty easy. I would tend to do Sperling's test, push it across this way, so lateral flexion, extension and rotation, and see if it traps the nerve in the neck. It's one of my favourite signs. It's not even a shoulder sign, it's this neck sign, looking for nerve root entrapment. If they get pain shooting into the arm, tingling, it's a neck. And I do remember a guy who came along to see me once who had absolute classic of that, and we've had a huge number of times, but this guy had previous surgery and hadn't got better from a shoulder surgery by someone else. And all along he had this pain felt here going down the middle scapula, referring to his arm with the classic Sperling's test. We go to move the shoulder. Well, we start off with a look, feel, move in orthopaedics, right? The rule of threes again. They keep appearing every time, that number 3. Okay, you go out at a party, you always go up with, often in group of 3, and everything happens in threes. Maybe not. Well, maybe not all the time. And I'll leave that to you. Anyway, so we go to examine, right? We're going to look, and we tend to look at the area and look at the shape. You can see the AC joint in this area, you can see the lateral acromion, you can see the coracoid. And we tend to feel, and if the tender at the sternoclavicular joint, they've got a large lump there, and it's a lady presenting with a lump and a swollen at the sternoclavicular area, it's an arthritic sternoclavicular area. If they come here and he's been playing footy, had a fair few knocks, and he's got a very prominent AC joint, he's been tender there having fallen, we think AC joint pathology. Come into the subacromial space, and it's more tender of the humeral head. Now remember, the humeral head sits more anterior in the acromion, underneath the acromion. It's not actually right on the middle of it, it's halfway across. So if it's tender in the proximal humerus, we're thinking more of the cuff. And you can feel the bicipital groove pretty easily, and we'll show that on Aidan in a sec with the ultrasound. But you can feel the bicipital groove by putting your arm in this position and just internally and externally rotating it. You'll feel a little groove in the biceps tendon. If it's tendon along the biceps tendon, you're thinking bicipital tendonitis. It's not that hard so far. Turn around, you're thinking supraspinatus fossa, infraspinatus fossa. If there's muscle wasting there, there's maybe a tear, okay, or weakness, and they haven't rehabilitated properly or prehabilitated. So we look and we feel, and then we go for motion, and this is where the real money is, okay? So it's a piece of cake. I actually can't do this without putting my hand on the shoulder and ask Aidan, put your hand up, and I always put my hand there, and I'm feeling for crepitus. You get soft tissue crepitus or you get bony crepitus. Soft tissue, tendonitis or bursitis or maybe small tears. Bony crepitus, arthritis. Forward flexion all the way up and down, okay, and then we'd face the audience there, and then when I go to this part, abduction, I will tend to actually turn around a little bit for a second. I tend to put my hand on the scapula, the angle of the scapula, and I'm seeing if the scapula moves early, and we abduct your arm out the side, and we see how much abduction there is, all right? And then turn around and face the audience, and just tuck your elbows into your side, and turn your arms out, external rotation. Right, so it really comes down to a couple of things, okay? So if he's got full motion, all right, but a painful arc, okay, then we're thinking impingement. Either bursitis, tendonitis in his age, tendonitis at my age, or maybe a small cuff tear at my age, or a bigger cuff tear, okay, painful arc. If he's got full range, but he's got pain at end range of motion, and he's tender at the AC joint, I'm thinking AC joint arthritis, okay? And a good test, a really good test for that, you can do the pull away and the cross arm, the scarf and all that stuff. I've never seen any of those work. A great test is someone showed me from Victoria, arm across here, elbow straight, push up against resistance, and that puts pressure on the AC joint. And interestingly, the reason AC joint pathology is more problem is exactly when you do your push-ups. Okay, it puts a lot of force through your AC joint. Okay, that's really good for AC joint. So once we've done that, okay, that's the full range of motion with some painful arc. If he goes to lift his arm up and he hitches, right, so you go hitch your shoulder up, right, so he brings them up and hitches like that, okay, we're thinking, oh, the shoulder's not moving that well, okay, not that hard. So then I've got to see whether it's passively it's moving fine or not. So just turn to your side again here, and I'll put my hand on the scapula and I'll lift the arm out the side. If passively he's got good range of motion, but actively he's hitching, then basically the arm's not moving. It's very easy, right? And what's not making the arm moving? Well, it could be there's a massive rotator cuff tear, or it could be a neurological cause, like C5 nerve root. And of course, if the Sperling's test is positive initially, or if he's got a story of having previous cuff surgery, then that would help us, all right? So full range of motion, passively, actively weak, we're thinking rotator cuff tear or maybe C5 nerve root. If, however, he's passively and actively, there's reduced motion altogether. So basically it hitches and you can't move it anymore. And that is shown really well on external rotation. Okay, so when you like later on tonight, Aidan's going off to surgery and I'm going to fuse his glenohumeral joint. Okay, I'm going to stiffen it so it doesn't move at all. All right? And what's going to happen, guess how much he'll be able to move his arm down to tomorrow? I'm going to do that because what's happening is the scapula's moving with him. But because the scapula can't hit against the rib cage, because the rib cage are protecting something important, I don't know what, but it's hitting that, you can't externally rotate. So if you've got a stiff glenohumeral joint, after his surgery, he won't be able to externally rotate, he'll be stuck like that. So if he's got actively, he's got reduced motion, passively he's got reduced motion, and he's got reduced external rotation, I'm thinking stiff glenohumeral joint. And if this joint's stiff, it can either be from frozen shoulder or arthritis. And in his age, well, he's probably a bit young for frozen shoulder, but in the 20 to 50-year-olds, that group, it's usually about 30-year-olds onwards, frozen shoulder, the 70-year-old, you're thinking more arthritis. And how do you tell the difference apart from the feeling bony crepitus? An X-ray, which is why the most important thing I like, the first thing I do is walking down the hallway all the time is, have you got an X-ray? X-ray, and they'll come along with ultrasound, you've got an MRI, you've got a bloody, everything but a bloody X-ray. And I go, it's just like, I really want an X-ray. And I go, can I have 3 MRIs and 4 ultrasounds? I go, no, can I please have an X-ray, please? And so, because it helps you a lot, okay? Now, if you, now once we've tested the active and passive range of motion, and if he's stiff, we know it's frozen shoulder or arthritis, we can test muscle strength, but we usually test muscle strength for the painful arc. And we can test external rotation, tuck your elbows into your side, push out against me. So, and testing external rotation, the infraspinatus, arms like this for me and push up the ceiling, supraspinatus, and of course you do belly press test for testing subscapularis. And if you really want to include your friend in it, the one that does nothing, you can test teres minor by bringing arm in here and do a horn blower sign. Push up this way for me, and horn blower sign it for teres minor. Okay. Once we've done that, we know the muscle power, the rotator cuff issues. Really, all there else is to do is just decide whether there's a biceps involved, where we can test if it's tendon on the biceps, and if you had a positive, we could do flexion against resistance, and feel if it's tender there. You can get caught up with the Spears and Jurgensens and all that sort of stuff, but it doesn't really change anything. We can test for O'Brien's test, but I find it very, very inactive, unreliable, because of the fact that when you get the arm in that position, it's also the impingement position, and also labral tears aren't that common to cause issues, so I didn't get caught up in that. So really, I just try and keep it simple. And then, once we've gone past that, we get an X-ray. So I'm going to let you sit down for a sec, Aidan, and we'll call you back up in a minute for the ultrasound. Grab your shirt. Okay. And so we get an X-ray, and an X-ray will help us a lot. If we go to the pictures here, here the X-ray shows nosochromiality. You've got to see it very subtly. But here it shows a big spur, which will help me show it's actually, that's more likely to be associated with a cuff tear. And here, the whole humerus is subluxated superiorly, which shows a rotator cuff arthropathy. I don't need an MRI for any of these things. It might help me plan my surgery, but it won't change anything I do. So if we move on, so when you go to assess the shoulder, it's just as simple as this little pathway. Now that looks a bit complicated, but it's actually not that. It's basically all I've done is put on a little flow diagram. And what have I just done? Oops. So yeah, but when we come to it, people get caught up in the whole treatment thing. Now I know I work at a rapid shoulder clinic, but most shoulders don't need to have surgery rapidly. We usually try other things pretty quickly. I mean, if you come off your motorbike and you tear your rotator cuff, that's a different story. But most shoulders, we can try simple things first. And I would do that for nearly all my patients. Now, I have heard one of my colleagues many years ago say, if I don't operate on them now, someone else will operate on them. I don't know that's a good excuse to operate. I just think you want to treat the patients. I just want to treat the patients the way I'd like to be treated. And I always try the simple measures first, okay? If they don't get better with the simple measures, then I go to surgery. And then you know you've done everything right. And that's why I involve the physios and the hand therapists and everyone involved in the care. Because really it comes down to giving it time. And that's calendar highlight, 3 months usually to see if they get better, if they've got a rotator cuff problem. Okay. Now, if it's an instability episode, we didn't go through instability with Aidan before, but if they had dislocated their shoulder, that's a different story. If Aidan dislocates his shoulder tonight at footy practice, a first-time dislocation, it's like an ACL rupture. And they're the ones you do recommend surgery on to stabilise them, because it's just like an ACL rupture, it can lead to instability, lead to arthritis. If Aidan dislocates his shoulder, he rips his labrum apart, then you would stabilise that earlier. It is an indication. We'll go through that in a second. But for most other rotator cuff problems, or if it's referred from the neck, of course, or if it's a frozen shoulder, upper limb or physiotherapy is the way to go. And you try the physio with a TheraBand, you might try steroid injections. Okay, now a lot of people don't like doing too many. I'll probably do a couple of them, but usually it might help to get them over the line so they can still work away with rehabbing. If you can give it time and get better, you can avoid surgery in that scenario. Because really, what it is the rotator cuff problem. We're all hooked up on what we do in surgery anyway. Well, the actual underlying problem is degeneration. Okay, so I say to people say, what causes most of these issues? And I go, well, it's the last 2 digits on the end of your birthday for a lot of the rotator cuff issues. See, mine's 66. If mine was 96, I wouldn't have anywhere near as many problems, right? And that's what it's a part of ageing, okay? And as part of ageing, smoking makes you age. And of course, genetics affects you too. We all know someone who's about 120 years of age and look like they're 50. So, well, maybe we don't know anyone's 120, but it might be a slight exaggeration. But the underlying problem is intrinsic cause of the tendon. We used to always think and get hooked up on this spur catching on the tendon, and that's what we mainly operate upon when we do a decompression. Okay, but the actual underlying problem is the rotator cuff itself just degenerating and aging in itself, and that's the problem. So, and therefore the secondary factors are really an aspect to it. So when we do surgery, this is the spur we're shaving away to make it nice and flat, and of course, if there's small cuff tears, we can repair them all through a telescope. And if there's bigger rotator cuff tears, you can repair those also through a telescope. I'll just let that run while I'm speaking. But the underlying problem itself is the actual tendon itself just degenerating. And this is how we repair a rotator cuff. This tear is about 2 centimetres in size. This is all done through 4 holes arthroscopic. I've been doing this since 2000 when I first came back, and I was one of the first to really try and do this sort of stuff in Adelaide. And most of people have been taught by myself to do this. So, but you put in a arthroscopic portals. You put an anchor, pass the sutures through the cuff. This is all through a keyhole. You actually get a better view than you do it open. Retrieve the sutures. And this is on the website anyway, so if you want to have a watch it as a highlight video for your friends on a Saturday night, perfect. So couldn't think of anything better, really. It doesn't actually take 3 or 4 minutes in reality. But see, we pass the sutures through the cuff, and this operation was done at Ashford. Actually, it's been recorded with the gear there. And once you've got all the sutures through the cuff, you've got sutures going left, right, and centre. You actually retrieve them and tie some knots. I think in this person, in fact, I wish I just cut this down a bit because I put a second anchor in right next to it. Probably didn't need to do as many anchors in this one, but second anchor goes in. Try to let it go through. Once we've got these sutures in there, I'll let it go for a sec. We tie the knots, and really the treatment of the rotator cuff tear is to while roughing up the bone, it bleeds and it sticks to the tendon, holds it, and actually acts like glue. And that's why you have to put them in a sling for 6 weeks to actually allow that tendon to heal to the bone. We could probably start earlier motion because these sutures are particularly tough. Here I'm retrieving some sutures. You can see, you saw the big tear just with one suture. This just amazed me. I've did the operation. I've watched this about 400 times. And I'm still glued to the bloody thing when I watch it when I'm speaking to you. Because you put one stitch in, and it looks like a mess at the moment. You pass a sliding knot, one stitch, you can't see the tear anymore. How weird's that? It's just so crazy. But I think the reason is, with arthroscopic, because you're starting more medially, you actually, and the tear is like a triangle, as you get closer to it, it doesn't take a lot to bring the tendon together against the bone. So it's all just arthroscopically. So you don't need to do an open cut to do an arthroscopic repair. So all my shoulders, I haven't done an open cut for ages. I do arthroscopic decompression, AC joint excision, bursectomy, and cuff repair, all through 4 or 5 little holes. So only gets one item number usually, so it's not that good if you. So, but it's what's best for the patient. So it gives you an idea of it. Okay, I better move on. So, but of course, the problem is it doesn't all come down to the surgery or even the rehab. I think Hannah was just mentioned before. The actual it's more to it. It actually depends on a lot of factors, and of course, it depends on patient expectations, their general health and fitness, whether they smoke, whether they've actually self-esteem and resentment at work, all these things. Now don't tell anyone I'll put this slide up. I actually wrote this slide up myself. They think I won't be an orthopaedic surgeon writing all this stuff, right? Because we're not supposed to talk about this sort of stuff. But really, it's all about psychological factors as well as. And to be honest, if you have a patient who's a heavy smoker, and you say to them, "Look, you really got to stop smoking. It's bad for the cuff," and they try and they stop, I usually think it's a good sign they're going to do quite well because they're actually pretty motivated to do it. If they say, "I'm not going to give up at all," I'm a little bit worried that maybe they don't have as big intentions to try and work. So it's almost a test to help them get underway. But also the smoking does inflame the nerves, inflames the tendons. And, but, no matter how hard you try, you might have, if they've got inappropriate expectations or poor social supports or with a lot of work resentment, you may not get them back to where they want to be. But if you have all those things coming together in the right patient, then usually things work really well. Of course, the advantage of the X-ray is really just also exclude arthritis. Now, if you've got arthritis in the shoulder, that's completely different to rotator cuff issues. And luckily, arthritis in the shoulder is not as common as the rotator cuff issues. It's probably about 10% of the patients I see. But we've been given a gift. I don't know if you're religious or not, but it's almost like a gift from God because these reverse shoulder replacements are fantastic. They're better than we all thought they were going to be. Obviously, if you're lucky enough to have primary arthritis, we can do a shoulder replacement. We replace the ball with an artificial ball and the socket with a plastic socket, which you can barely see. There was a little white line just there. Okay, but if the cuff is deficient and the humeral head is subluxated, you can't do that because of the instability in the rotator cuff, it will wear out. So you have to do reverse shoulder replacement. And so we put the ball where the socket goes and the socket where the ball goes because we read the instructions wrong. No, really because it's designed back in France predominantly and to help balance the shoulder and allow the deltoid to do the work for it. And it's actually amazing. And not only are these done for, in fact, you might, if you look carefully, you might see this has actually been done for a fracture, this one. But it's been done for fractures because that's when in the fractures often the grade tuberosity, or the tuberosities pull away, and so it's done as a way of actually compensating for the deficient cuff that could occur down the track. It's also been done for people with massive rotator cuff tears, or it's done for arthritis with people with rotator cuff tears as well. So probably about, I think most of us are probably finding 80% of our shoulder replacements are now reverses, where it used to be hardly, most of the shoulders we used to do were what we call primary anatomic shoulder replacements. And frozen shoulder, that's the one I get lots of referrals from, and it's just the one, really, when you see these people, you just want to give them a big hug, because they're miserable. It must be awful, the condition. It's awful pain, it's searing, it's almost like a neurological type pain. They're losing sleep, they're teary, and it's very hard. And the problem is the time when you want to operate on them is probably not the time they should be operated. The longer you wait to treat them, the better you do. In fact, I hardly ever operate on frozen shoulders anyway. It's usually a time factor. It usually gets better on its own. And in fact, nearly always gets better on its own. It's just a matter of just counselling through that part. And the frozen shoulder, where they present with initially pain, and they get pain and stiffness, and then then the pain goes away and just remains stiff. And by that stage, they're happy because the pain's gone. And then with time, the stiffness gets better. And that's where hydrotherapy and physio and all sorts of upper limb therapy, all very good, okay? We're giving it time, and if you do an injection, if I see them today or I see them 3 months later and do the injection 3 months later, they'll do better 3 months' time, because you have to wait for the whole condition to run its course. No one really knows what causes it. It's a weird condition. It's awful, and the role for arthroscopic releases or manipulations are few and far between in my hands nowadays, because usually you get better with time. And in fact, I've had ones where I've gone in and really don't know if it's made a big difference. So I think certainly the patients have had ages, have tried the injections into the joint to try and release the shoulder a bit, have tried lots of physio and hydrotherapy, then I'll do a release in that scenario. And it's usually an arthroscopic capsular release where we go in and divide the capsule, being careful to avoid the nerve. Shoulder dislocations, different set of group. These are the unstable shoulders, and really the classic is the instability where the shoulder pops out of joint and tears the labrum off the glenoid. And those ones will often be repaired with a primary repair. It's all done through keyhole surgery again, all arthroscopic. However, these patients are more likely to have some instability issues. So if we call Aidan back up again for a sec, and we won't get you undressed this time, we'll keep you. But if we go through and just go through the instability signs, because I've got no hope of doing this now, but so when I see a patient with a history of instability, I would test to look for ligament hyperlaxity, so elbow hyperextension, thumb hyperextension. You can bring your thumb back onto your forearm for us, around down this way, bend your wrist and your thumb this way, so like that, around down that way. There we go. And he hasn't got either of those. He can't hyperextend his elbows, he can't hyperextend his thumbs, can he hyperextend his fingers, can he hyperextend his knees, and can you touch your palms to the ground without bending your knees? And so he's very unlikely to dislocate his shoulder. If he does, it's more likely, because he's got a bit of stiffness, to rip off a bit of bone with it as well and cause what we call bony Bankart. Okay? If they've got ligament hyperlaxity, they're the ones that go into recurrent instability. And when we assess, if Aidan did have ligament laxity, I know he plays footy, he's a young guy, he's injured it while going up for a ruck or something, or for an overhead mark, we'll assess his what we call injury severity score to assess whether he's more likely to redislocate. And in his group, he'd probably be up there, in which case, rather than just repairing the labrum, we would actually need to consider whether we do a bony procedure, which is just there, where we actually take a bit of bone off the coracoid and put it in its place. And that's called a latterjae. That was made quite popular recently, or a few years ago, by one of the famous AFL footy players who had an arthroscopic repair and then it redislocated and went for the bony, and that got him back and finished his career with that. So the latterjae is now very common in AFL footy. We'll move on. Go to elbow conditions. Really the same, and I'm probably getting close to running out of time. So, but the elbow conditions really comes down to the same scenarios. And in fact, I'll just go back. Really the same situations: fractures, dislocations, infections, and tendon tears. In the elbows, though, we're also thinking about the nerve conditions too, the cubital tunnel syndromes that go on as well. So we've got our tendinitis, biceps, triceps, epicondylitis, the bursitis, the student's elbow, the cubital tunnel or posterior interosseous nerve, and then the arthritic elbow. So really it's not that hard. There's not that many things that can go on. And a lot of the elbow conditions are treated conservatively. Elbow arthritis, for instance, leads to a stiffness. You'll probably see in patients that come along, they've got a stiff elbow. But really, in that scenario, you can do open debridements for them, even arthroscopic debridements, but the underlying arthritis is still there. And you can't expect a lot out of that. The elbow replacements are a very varied group, and I stick away from elbow replacements because they do have a high complication rate, but there are some surgeons who do them, and I think the few that are required are probably best going to those, my colleagues who are actually happy to do them, because I don't think unless you're getting a large number right up there, I don't worry about them. But all the others, the epicondylitis, the tennis elbows and golfer's elbows, it really is a place of giving it time to heal, and it involves upper limb therapy, sometimes steroid injections, and occasionally surgery if they're not getting better. So when we look at we've got our tennis elbow, golfer's elbow is one of the most common things you'll see, but again, it's the time to refer to a surgeon is once you've tried some therapy, okay? Try some upper limb therapy or physiotherapy, whoever you refer to. Try, if that doesn't work, then try a steroid injection or maybe a platelet-rich plasma injection and give it time. Tell them to rehabilitate themselves. You know, you've got to look at that other chart we talked about motivation and supports. Make sure they're not smoking. Make sure they've got their weight under control. Make sure they're fit. And if you get them in perfect health and they're still not getting better, then occasionally what surgery is indicated, and that's usually an epicondylar type slide. Some people will try and repair the tear in the tendon, but really most of us try and make the tear bigger so it takes the stress off the extensor carpi radialis brevis, which is what's causing the pain. Cubital tunnel, there's the thing you put off your tenor for you, so there's a slightly bigger release. That actually looks worse on that photo, but you can see the ulnar nerve just there, sitting across, and that's a transposition. Very common, 1 in 5 of you will have a subluxing ulnar nerve, and that can cause pain, and may cause a medial elbow pain, and often you'll get some ulnar nerve symptoms associated with that as well. If people are just like a carpal tunnel release, if their nerve is getting trapped, a cubital tunnel release is a very good procedure. And my second favourite test for anyone, apart from the Sperling's test, is Tinel's sign, testing for nerve, either carpal tunnel or ulnar nerve entrapment. So if you tap along any of the nerves, you can actually, if it goes hypersensitive, it's a sign of where the nerve's being irritated. Going on distal biceps, more and more common now. It may relate to the fact that there's so many people doing so many weights. Some people also may relate to the use of steroids and things as well. But I think probably the main reason it's been picked up more is that we're all more switched on to it as well. So and the easy availability of ultrasound. And usually distal biceps, as opposed to long-headed biceps, which doesn't cause that much issue apart from the cosmetic appearance, distal biceps can lead to weakness, particularly of supination. I still, in my own heart, believe that it probably doesn't make. I've got patients who haven't had surgery and they've done very well, but most distal biceps I would offer surgery and give them the option. So, but I'm not certain that you have to have surgery for distal biceps. I'm probably a bit out on the wing that way, but I would still always offer it. And Radiohead fracture, I like this one because this is my favourite one for the medical students because it's one of the few fractures that the trick is, I would say, if myself and Aidan, who's just finished med school, comes along and we see a patient and I completely missed the Radiohead fracture and tell the guy to get on with it. He's just being, he's soft and needs to get his elbow moving. And Aidan's obsessive about it, picks up the Radiohead fracture and puts the patient in a splint or a sling and keeps it still so it doesn't move. Which patient will do worse? And the answer is Aidan's patient because they've kept it still. The treatment for most Radiohead fractures is to get it moving. If it's displaced that needs surgery, like the ones in that middle picture, which is the surgery at the top, then fix it, get it moving. And if it's associated with a complex scenario, that's a different situation. That's what they call Monteggia variance. But a simple Radiohead fracture, get it moving straight away. Come to hand and wrist conditions, we're really pushing along now. So really you can divide them up into those other things. Hand and wrist is the hardest one to assess because there's so many different areas. But if you divide up into painful conditions, neurological conditions, or other deformities like the Dupotrons or the myxoid cysts or the arthritic cysts, then it gets a bit easy. If you look at the painful conditions, you divide them up whether it's on the radial side, middle column or ulnar side. It helps you. And then carpal tunnel. And the good thing about these sort of procedures is the carpal tunnel, in fact, I probably do about 100 carpal tunnels a year, and they're all under local. So occasionally with some sedation, but all under local. Just put local anaesthetic in the hand. Patient's wide awake. It's a very cheap procedure. We do that also for trigger finger releases and also the quervains. So they're wide awake. They don't need an anaesthetist. They don't, if it's funded, we get an assistant, but we don't have to have an assistant otherwise. And and so it's a very cheap procedure. We've done as a day case, very safe. And that elderly lady who's 93, who's a bit worried about the anaesthetic, if she's got carpal tunnel symptoms, can try have surgery and does very well. Now, people talk about the advantage of arthroscopic or endoscopic versus open. Really, the incisions heal fine, and most of the people aren't rushing back to work. But I don't think the actual open versus endoscopic makes much difference for return to work. I think it's more up here, how quickly they get back. And we've seen that, you've all seen that recently with the some of the types of, I don't do hip replacements, some of the hip replacements they're doing, the people have done the anterior approaches, I think they do a lot of them at Flinders, and they get back quickly. But even the ones who do the lateral approach or posterior approach, if you give them the right mindset, they get back quickly as well to these sort of things. So it's actually, a lot of it's the mindset of the patient. And we've seen that in people with having babies and staying in hospital. CMC arthritis, really common. And it's a good little operation just to release, there's the arthritis at the base of the thumb, you just excise that area. But you'd always try a steroid injection, always try a splint, give it time, see how they go. But if they're not settling, then a trapeziectomy, excellent operation. And that can be assessed just by pure pain in that base of the thumb. And the quervains, again, a little simple procedure where you release the first sensor compartment. I didn't put it in there, but the most common cause of the quervains, I think, relates to a new pet or a new baby. Okay, I'm picking it up the baby or the pet, and that's the most common reason I see them. Dupuytren's contractures. I worked in Scotland for 5 years. Every second person had a Dupuytren's contracture. I remember when I went away over there, I was talking about all these reasons why they occur. I got there and everyone had one, and I was pretty obvious it's genetic. So we got a lot of exposure to that. And scaphoid fracture. Now this is one, everyone knows scaphoid fractures. You never miss them because they're sore. But no, I've actually, 2 or 3 patients a year I see have had missed scaphoid fractures. You'd think that'd be impossible. But I remember one guy was doing a drill in the wall, and the masonry bit hit the wall, and he torqued his wrist. And he came on, my mate, he's on, I won't say, but he's on a podcast, one of my podcast people I interviewed. He was, I was at the cricket, and I sat down next to him and he said, I caught my lad's soccer ball and forced my wrist back. And he said, I've got a bit of a sore wrist. And I said, have you seen the doctor? He said, my mate's GP said it's fine. I said, well, if the x-rays are okay, you could get an MRI or CT. He goes, I haven't been x-rayed. And my response was the GP got x-ray vision because he was really sore there. And so I just went straight for an MRI in his situation because it was easier. But it would have been picked up on a CT, or even I think actually an x-ray would have shown it in the end. And he had a scaphoid fracture. He's a surgeon. So he actually had that. So it's actually surprising how easy it is to miss it. So be aware of it. And just because that was a soccer ball hitting the hand is the same as him falling on the ground and forcing his wrist back. Okay, the drill is torquing his wrist. So yeah, and if they go on to develop arthritis later on in life, you can actually, as a scaphoid non-human with arthritis here, you can actually take the scaphoid out and do a full corner fusion, which is a really good operation. And Charlotte's team would have seen a few of those come through from me. It's not saying you do a heap of them, but you're probably a couple a year. But it's actually really good results from that. It ends up with a slightly reduced range of motion, but it's a good operation for it. So just to reiterate, and I just quickly want to show you just how easy this ultrasound thing is. I thought this might be interesting. But so I'm going to borrow Aidan's wrist for a sec and hook up the... we'll see how we go. All right, check it out. I'll come around this side, I think, and come over this way here, Aidan, so I can see that screen. And we'll go over here. And there we are. And move your finger up and down for us. There we are. You can see the antenna moving. We go further. Just keep your finger still for a sec. Go distally. You can see the metacarpal phalangeal joint. Go back up this way. See the tendon there. Move your finger up and down for us. Excellent. If we go across to bring your wrist slightly. In fact, there it is there. You see the carpal tunnel there. And if we just go, move your fingers up and down for us, you can actually probably increase the depth on that. Going the right way, yeah. There's our carpal tunnel. I'll just come across this way. And just in this area here, If we try and expose it, we probably see, it's always hard to do it in front of 50 people, but well, you see the tendons there beautifully. Just move your fingers again for us. And just over, I had it before, just there we'll start seeing, see the gap is where the median nerve is. And move your fingers up and down, and there you can see the muscles over the top of the carpal tunnel region. So you can see it's a fair bit to see, and good for patient feedback, and you can do it on the shoulder, on the elbow, and it's just something we're just incorporating in the practice. So yeah. Okay. I'll let you enjoy your dinner then in peace. So okay, thank you.